Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarnet serves as a digital partner for this event, and the focus of today's session is anesthesia for orthopedic surgeries. Now, I would like to invite Dr. Meenakshi Sundaram sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Penny and Stanley Medical College, Chennai. He is a former National Vice President of Indian Society of Anesthesiologists and has held key positions including Governing Council Member President and State Secretary of ISA TamilNadu State Branch. So now, without further any delay, over to you, sir. Thank you.
Thank you, Cleveland. Today we are having a wonderful webinar on orthopedic surgeries, and this Puthukkottai Bhudhan Second Edition so far conducted a weekly webinar continuously, and we are completed many CMEs. So last CME was in anesthesia on trauma. So at that time, many people wanted this fracture neck of femur to be included. So we wanted to have a separate orthopedic anesthesia as a webinar, and see if it is orthopedics in the countrywide, the popular hospital is Ganga Hospital. So we have selected Ganga. So either if I am not selecting Ganga, it will be Sanchiti Hospital, Pune. But see, the widely acclaimed hospital for orthopedic and plastic surgery throughout the world, I can say it is Ganga Hospital. So we have fixed Ganga Hospital anesthetists to talk on anesthesia for orthopedic procedures, because right and left they are doing ortho procedures, because they have 20 operation theaters over there. So the youngest faculty today will be Dr. Reena. Dr. Reena did her undergraduation in MMC, and currently she is doing her final year in Ganga Hospital. And just because she is overloaded in orthopedic procedures in Ganga Hospital, her face itself says that she is overloaded. So it is very difficult to smile during post-graduation. That too, post-graduation in Ganga Hospital, it is all the more difficult. And we are happy to have Dr. Reena as a faculty here to talk about the complications. That is fat embolism, which is a commonest complication in long bone fractures. And it will be followed by Dr. Aparna Jayaraj. Dr. Aparna Jayaraj, orthopedic anesthesia, it is very difficult to believe, because I think she can become a neuroanesthetist, because she is as fat and as thick as a nerve. So that is her stature. But she has come for orthopedic anesthesia, and she has done her MBBS in JSS Medical College, Mysore, Karnataka. The funniest part is, originally she is from Kerala, and she has done her undergraduation in Karnataka, and she is settled. She has done her post-graduation in Odisha, that is Kalinga Institute of Medical Sciences, and she is settled in Tamil Nadu. So she is in charge of 4 states: Kerala by birth, undergraduation Karnataka, post-graduation Odisha, and settling in Tamil Nadu. And she is a faculty in all workshops, especially in regional anesthesia for orthopedic procedures. So necessarily she is in all ISA conference and AORA conference. AORA, even Ganga Hospital has conducted so many years, AORA. So these people are continuously in workshops. And the peculiar part is, she has been a faculty in head-to-toe scanning. See, imagine head-to-toe scanning. She was the she's a faculty, and her area of interest will be perioperative management and trauma, all orthopedic procedures. Then spine surgery, difficult airway, and orthopedic anesthesia procedures. So it will be followed by Dr. Stephen Jayaraj. We have some affinity to Stephen Jebaraj, because she's from Puthukkottai. The branch is organizing this webinar continuously, and she's from Puthukkottai. I don't know where he has done her schoolings. It may be in Puthukkottai itself, like me. I am happy I have done my from second standard to +2. I have done in Puthukkottai only, all government schools. I was not privileged to be educated in a private school, so I was in all the way in government schools only. So Stephen is from our place, and now she is a consultant. He is a consultant in Ganga Hospital, and he has done his MBBS from Thoothukudi Medical College. But again, people who are learning and who are teaching, they will be exclaimed everywhere. They have all the accolades. So he has done his post-graduation from BJ Medical College, Pune, Maharashtra. BJ Medical College is a popular medical college in Pune and KEM. So he has obtained his post-graduation from BJ Medical College, and he has awarded that fellowship degree in a regional anesthesia from Ganga Hospital. As usual, as he is in Ganga Hospital, he is a faculty in all regional nerve block workshops. Again, he has also participated in that head to toe scanning because that is compulsory for a person working in Ganga Hospital. And see, he is a football player. So he's a football player, but he will not throw or kick the patients. So he will take care of the patients, but he's a football player. And again, he's interested in geriatric anesthesia and spine anesthesia and difficult airway. Now the question comes, if these three people has to be moderated, so we wanted a senior consultant to moderate this junior consultant of Ganga Hospital. So he is Dr. Gurumoorthy. He did his UG from Madras Medical College. And again, he has done his post-graduation from Madhya Pradesh. So it is from Jabalpur, Netaji Subhash Chandra Bose Medical College. And he is an invited faculty for many CMEs. And his hobby is aerobic exercises. So just like organic and inorganic, nowadays the popular thing is aerobic and non-aerobic. So he is a aerobic exercise person. He is also interested in geriatric anesthesia. Now I wonder, all these young anesthesiologists are interested in geriatric anesthesia. I don't know why it has happened. Probably their workload on geriatric side is very much necessarily they may be interested on that. That is, you have to develop interest in some field, or you have to like the field in which you are there. I think these youngsters are having a geriatric population, so everybody is interested in geriatric anesthesia. So I am very happy now. I am young, so when I have become a geriatric, these anesthetists will come for my help. With this introduction, I hand over the session to Dr. Gurumoorthy. Please take over.
Sir, good evening, sir. Good evening, everyone. Thank you for the wonderful opportunity, sir. I feel I hear the number of people attending every time more than 800. It is very huge number. It is a remarkable way of educating all anesthesiologists, especially young anesthesiologists. So before going into the topic, I want to introduce, like, India is becoming better and better. As we all know, road conditions are becoming better. Number of 4 lanes are coming in a big way. At the same time, unfortunately, we are facing with a lot of road traffic accidents, especially long bone fractures numbers are increasing, and polytrauma number of polytrauma also heavily increasing. I think it's ideal, and it is important to know all the young anesthesiologists, all the anesthesiologists should know how to manage fat embolism. Especially a lot of young people are getting into this trouble, and we should know how to make it better, and when to optimize, and how to optimize, and when to choose them for surgery. That is what we want to know from this topic. And after that, I think one more topic, interesting topic, that is how to manage the neck of femur fracture. That is day to day every anesthesiologist face. Many of the old people are, especially this neck fracture, hip fracture people, many people are sick. So only relatively few people are healthy. So we should know how to make them, optimize them better. Then how early we how to post them, and how to come out of, make them better after the surgery also we should know. And third topic also very much relevant. They are related all, that is knee replacement concerns. That is usually people are most of the people are healthy geriatrics, but they need some rehabilitation. I think after the talk, we will come to know how to improve the skills to manage those relatively healthy geriatric. Some of them come with compromised geriatric people also come for that procedure. Then for them, we have to give them some time to evaluate. Then we have to take it. I think I will start with the first speaker, Dr.Reena. I think you can proceed.
Good evening. Good evening, everyone. Thank you, sir. Thank you for introduction. I thank ISA and Dr. A.L. Meenakshi Sundaram, sir, and Dr. Shekhar, sir, Balavenkat, sir, and Gurumoorthy, sir, and all other consultants from Ganga Hospital. Thank you for the opportunity. Today, my topic is fat embolism and anesthetic implications. A fat embolism is the presence of circulating fat globules in the circulation and a pulmonary parenchyma. The fat embolism and fat embolism syndrome are both different entity. Fat embolism syndrome is the symptomatic, that is clinical manifestation of the fat embolism. Fat embolism is the asymptomatic entity. And fat embolism syndrome, it exists as a triad that includes respiratory insufficiency, altered sensorium, and petechiae. The causes most commonly seen in trauma, that is long bone fractures. These are seen in younger population, mostly from high velocity injuries. The incidence is around 3 to 4%. And in case of multiple fractures, the incidence raises up to 33%. And it is common in trauma surgical procedures like intramedullary reaming, high velocity intramedullary reaming, or forcefully reaming the canal. And in surgeries, unseen in surgeries like hip and knee arthroplasty. Non-traumatic, non-hydrogenic causes would be sickling crisis, pancreatitis, fat necrosis of omentum, hepatic steatosis, osteomyelitis, panniculitis, and bone tumor lysis. Coming to pathophysiology, as it is the disease process is uncertain, there are many theories proposed for fat embolism. First theory is Gauss's mechanical theory. Here, the long bone is fractured, and the fractured side, the fat molecules are released into the circulation, and they can travel via the venous capillaries and end up in pulmonary capillaries, and they cause the damage like alveolar collapse, interstitial hemorrhage, and edema. These are the changes can be seen in pulmonary capillaries. And coming to biochemical theory, which is proposed by Lehmann's biochemical theory, here the neutral fat is non-injurious to the lung. But when the fat is hydrolyzed by some enzymes, lipases, and they convert into free fatty acids, these free fatty acids are responsible for the inflammatory cascade, which is causing the acute lung injury and ARDS-like features. And then from there, the fat globules from the pulmonary circulation, it can enter the systemic circulation via the patent foramen ovale and can travel to the systemic circulation and results in cerebral infarctions and dermatological manifestations like petechiae, renal manifestations like oliguria, lipiduria, and in hepatic it can present as jaundice, and in retina they can present as retinal hemorrhage and macular hemorrhages, and cotton wool exudates can be seen. Systemically, there can be a temperature a rise in temperature, fever, and in cardiac there will be hypotension, arrhythmias, the hypoxia resulting in pulmonary artery hypertension, and finally it can lead to pulmonary artery right-sided heart failure. And in hematologically there will be anemia, thrombocytopenia, and all those steps. Coming to clinical manifestation, as it is a clinical diagnosis, but it takes time for the symptoms to present. Like it takes around 24 to 72 hours, and in sometimes it is as early as 12 hours to and late as 2 weeks following the trauma or surgery. There are three entities like subclinical phase, non-fulminant phase, and fulminant phase. Subclinical phase, hypoxia is the most common feature, like decreased PaO2 will be there, and minor hematological changes, and tachypnea and tachycardia and fever can be present in subclinical phase. Non-fulminant phase, it occurs in 30% of the individuals. Petechiae will be, dermatological manifestations will be more common, and neurologically patient will be presenting as confusion, stupor, and coma. Minimally there will be tachypnea, and then it can progress to ARDS like symptoms. And fulminant phase, it is a severe form of fat embolism syndrome. When a sudden large emboli, it reaches the circulation and it can cause severe respiratory failure and altered mental status. So this fulminant phase requires critical care management. Coming to diagnostic criteria, as it is a clinical diagnosis, where many diagnostic criteria are there to come to a conclusion that it is a FES syndrome. Like first, we'll see about Gertz and Wilson's, modified Gertz, Lindick's criteria, and Schoenfeld's criteria. First, we see about Gertz and Wilson's criteria. There are major and minor criteria. Major are the triad as such, like petike, hypoxemia, and altered mentality. Minor features would be tachycardia, fever, thrombocytopenia, unexplained anemia, anuria or oliguria, retinal embolism, fat globule in urine or sputum, jaundice, and high ESR. To diagnose this FES, there should be a 2 major criteria or 1 major plus 4 minor criteria. And then it's a modified Gertz. Modified Gertz criteria like 1 major plus 3 minor or 2 major plus 2 minor criteria. Lindick's criteria is most probably involving the respiratory components, PaO2 less than 60 mmHg, PaCO2 more than 55 mmHg, or pH less than 7.3, respiratory rate more than 35, and patient would be tachycardic and tachypneic. This Schoenfeld's, it is a recent criteria consisting of quantitative parameters, and the score more than 5 will be the cutoff point for the diagnosing FES. The parameters would be petike, X-ray infiltrates on chest, hypoxemia, mental confusion, tachycardia, fever, and tachypnea. Coming to investigations, as it is mostly clinical diagnosis, we can rely upon some of the investigations like complete blood count. There will be a drop in HP and platelets and increased ESR, hypofibronugenemia and prolonged prothrombin time and increased fibrin degradation products. Hypocalcemia would be present, hypoalbuminemia, fat globules would be present in blood and urine. And ABG, this is a most important investigation as hypoxia is the first common symptom usually seen in fat embolism. We should check for the level for PaO2 and then pH. Respiratory acidosis will be present and increased alveolar arterial shunt fraction would be present. Chest X-ray, we can see diffuse bilateral infiltrates. CT chest would be done, and MRI brain, we can see small cerebral infarctions. And in case of bronchoalveolar lavage and transthoracic echocardiography and transesophageal echocardiography, these are the images. Like first picture shows petike. Petike usually seen in conjunctiva, subconjunctival petechial, and then in face, oral mucosas, neck, shoulder, axilla. Usually the fat is a low density component, so it usually it will be in the non-dependent circulation. And second image is a chest X-ray showing a bilateral fluffy infiltrates, shows like a snowstorm appearance. And third image is CT scan of the patient showing like focal ground glass opacities and diffuse interlobular septal thickening will be present. Next image would be like MRI brain. It's a T2 weighted image showing a star field pattern of the cerebral fat embolism pattern, like punctate hemorrhage, multiple intense punctate hemorrhages would be present in the MRI brain. And the next picture would be autopsy picture showing that punctate hemorrhages. Next is a hematoxylin eosin stain of histology showing the fat globules. This picture, fat can be stained with Sudan black or oil redo stain. So it can show us red particles like fat globules in the circulation. And finally, transthoracic echocardiography. You can see the arrow mark indicates the fat globules running in the IVC. Coming to management, what are the anesthetic considerations? Mainly would be like patient will be presenting with hypoxemia. So hypoxia and hypoxemia, respiratory support, mainly of the supportive treatment should be done. Prevention and early prompt diagnosis with close monitoring of the patient with ABG or pulse oximetry is essential to diagnose and prevent it. Early surgical reduction with mostly with external fixation of the long bones, mainly tibia and femur. In case of any multiple fractures, go with the 1-by-1 fixation of the fractures. And immobilization of the fracture site is important. Early supportive care with the supplemental oxygen and early supportive care with supplemental oxygen and mechanical ventilation in case of severe respiratory failure. And we can give DVT prophylaxis if the platelets level or in normal limits. And what are the preventive measures when going for the surgery? The surgeon should clean the medullary canal with saline solution and aspirate the medullary content before nailing or reaming, using fluted intramedullary rods rather than solid rods, and venting and diaphysis distal to processes in case of TKR procedures, and using low viscosity cement, using processes without cement, and use of narrow reamers and slow insertion of nail, and decreasing the pressure during nailing, and use of reamer irrigator aspiration devices. And when to take up for the surgery. The patient presents with a fat embolism, and when we are deciding for the surgery, when the patient to be taken up for the surgery, patient should be like hemodynamically stable, all without any inotropic supports, or oxygen requirement should be low, not in mechanical ventilation or requiring more support in critical care. And close monitoring with ABG, arterial blood gas monitoring, and pulse oximetry would be essential before taking up for the surgery. A word about cerebral fat embolism. A cerebral fat embolism is a neurological manifestation. Patient would be presenting with altered mental status, seizures, coma, and then the lesions would be mainly in the deep white matter, brainstem, and cerebellum ganglia. MRI is very sensitive in diagnosing cerebral fat embolism. As I said, as I shown the picture, like star field pattern would be there. Multiple hyperintense punctate lesions would be seen in the white matter. And the CT scan can differentiate the head injury from a cerebral fat embolism. Mainly in fat embolism occurs in trauma, we should rule out the cranial trauma also. Like patient should be ruled out first trauma to the head, and then we can go for the MRI to diagnose fat embolism. And this is a study conducted in our hospital between 2012 to 2018 regarding can we rate the mortality or mortality with the cerebral fat embolism and MRI grade on recovery for the cerebral fat embolism. It was conducted in 34 patients. The result was like there was an increased rate of mortality in patients with cerebral fat embolism who had an early symptoms, and complete neurological recovery could be present in most patients who survived. These are my references. Thank you.
Now I invite next speaker. I think next speaker is Dr. Aparna. She is going to talk about neck of femur fracture, anesthetic concerns. Over to you, Aparna. Our geriatric population is steadily increasing. So what we saw 10 years before, more than 70, hardly we see more than 80 and 90. Nowadays, more and more people are, we are seeing like 80, above 80, above 90. Sometimes we see some patients nearing 100, above 100 also we have seen some patients. So every anesthesiologist should know how to manage these hip fractures, especially when to take and how to manage, how to make them better in the perioperative period.
Good evening, everyone. I'm Dr. Aparna. Thank you, ISA Puthukkottai and Meenakshi Sundaram sir for this opportunity. So today we'll be discussing the anesthetic considerations in a geriatric neck of femur fracture. Hip fractures are a very prevalent form of injury that occurs in over more than 1.6 million individuals worldwide, and they are associated with a high perioperative risk of morbidity and mortality. When we are managing a geriatric patient, we must account for their frailty, comorbidities, and their functional baseline. The 1-year mortality of Indian population in a hip fracture is around 18 to 20%. And the key preoperative predictors include advanced age more than 75 years, more than 2 comorbidities, low hemoglobin, delaying the surgery for more than 48 hours or more, and male sex. When we talk about the geriatric population, it is essential to mention frailty. So what is frailty? It is a clinically recognizable state in which the ability of older people to cope with everyday or acute stressors is compromised by an increased vulnerability brought by age-associated declines in physiological reserve and functions across multiple organ systems. There are various scales through which we can assess the frailty, and one such is the Canadian study of health in aging. Coming to the physiological changes in the elderly population. To summarize, there is a generalized decrease in the cardiovascular reserve, in the pulmonary functions, in the renal clearance, there is altered pharmacodynamics and pharmacokinetics, and there is increased risk of postoperative delirium. This is a flowchart summarizing everything in one slide. When we talk about central nervous system, there is a decrease in the brain volume, there is decrease in the cerebral white matter, there is decrease in the number of cholinergic and dopaminergic neurons and neuroreceptors, which results in a decreased level of ACH, dopamine, and other neurotransmitters. There is aging in the autonomic nervous system is characterized by a limited adaptability to stress. There is decrease in the basal activity of the parasympathetic system. There is activation of the sympathetic nervous system. There is decreased baroreceptor reflex and sensitivity, and there is slowing and weakening of the homeostatic functions. Now, how this affects us is the neurological dysfunction.
Dr. Aparna, sorry to disturb you. Whether your slides are moving?
Yes, sir. It is moving here, sir.
Dr. Guru, you can see that? Whether her slides are moving? You just move the next slide. It is not moving here because you have to share the presentation in a PowerPoint mode. Now you go to slideshow mode. Click slideshow. Yes, now it is moving. Do that.
Okay, sir. Shall I continue, sir, or start?
Yes.
Okay. Okay, so when we come to the autonomic nervous system, there is a limited adaptability to stress. There is a decrease in the basal activity of the parasympathetic nervous system. There is activation of the sympathetic nervous system. And there is slowing and weakening of the homeostatic functions. Now, how this affects us is that the neurological dysfunction of aging, along with the altered pharmacodynamics, it creates an increased sensitivity to the anesthetic medications that we administer. There is altered reflexes causing urinary retention, constipation. There is deterioration of gait and mobility. There are altered sleep patterns, and there is an impairment of memory and intellect. Coming to cardiovascular system, there is a decrease in the LV compliance and generalized hypertrophy. There are fibrotic changes of the heart and calcification of vessels, of valves. There is decreased myocardial compliance, decreased SA node automaticity, and there is a decrease in the heart's inotropic and chronotropic response to catecholamines. In respiratory system, we have a decreased response to hypoxia and hypercarbia. There is elastic recoil of the lung parenchyma is reduced, which it functionally resembles an emphysematous lung. There is less efficient alveolar gas exchange. There is decreased mucociliary clearance and protective reflexes, so there is higher chances of aspiration. And the compliance of the chest wall is reduced, which causes an increased work of breathing. So this causes an increased risk for a perioperative respiratory failure. There is reductions in the functional residual capacity in the supine position. Under influence of GA, it's further reduced and the stress of surgery can affect it more. The vital capacity is reduced by 25 to 50% from an inadequate post-operative pain management. Opioids also can cause alterations in the vital capacity, tidal volume, and respiratory rate. Another important aspect that we have to keep in mind is thermoregulation. The elderly are more prone to hypothermia because of the lower body metabolism, decreased thermogenesis, and a peripheral vasodilatation. Hypothermia can lead to CNS depression. There is depression of the ventilatory drive, which can cause postoperative somnolence and hypoxia. It accelerates protein catabolism. There is prolonged drug action, and there is increased myocardial oxygen demand. Now, once we have decided to take up a patient for surgery, what are our goals in the preoperative period? First, we have to identify the targets for preoperative optimization. Specific consideration should be taken for the medications they are on, like antiplatelet or anticoagulant therapy. Accurately inform the patient about the surgical risk. Not only the surgical risk, the risk related to surgery, the anesthesia, and what is expected in the postoperative period. Decision making regarding the surgery. It is an early optimization, early surgery, and quick rehabilitation is the way to go. Once we talk about history taking, it is essential to ask. Most of the patients presenting with a neck of femur come to us with history of falls. So it is essential to ask how and when that happened. A slip and fall can be simple, but if there is a history of unconsciousness or dizziness, that can indicate any other underlying conditions. Ask for their medical illnesses, the duration, the medications they are on, or any other complications associated. History of previous hospital admissions or history of previous surgeries and anesthesia. Assess their functional reserve and their daily activity. Do a minimal cognitive assessment. And coming to physical examination, along with your routine physical examination like vitals and systemic examination, check for potential IV cannulation sites, assess their spine, and assess their airway, because most of these patients present to you with difficult cannulations, difficult spines. So this is mini mental state examination, which can be a quick guide to assess their cognitive function. The minimum basic investigations required are CBC, RFTs, electrolytes, blood sugars, ECG, and chest X-ray. A preoperative cardiac risk assessment in older surgical patients is essential. The guidelines for specifically for 2D echo include a dyspnea of unknown etiology, signs and symptoms of a heart failure, and suspected moderate to severe valvular stenosis. This is the revised cardiac risk index. It is a very reliable tool to assess your cardiac risk. It consists of a few points, that is high risk surgical procedure, history of ischemic heart disease, history of congestive cardiac failure, history of cerebrovascular disease, diabetes on insulin, and preoperative serum creatinine more than 2. If there is, this gives us an idea of the predicted MACE. So there is no risk factors. It is 0.4. 1 shows you a 1% risk of MACE, and so forth. Optimization prior to surgery. The patient presents to you usually with multiple comorbidities, so it is essential to control the blood pressures, blood sugars, keep a watch on the electrolytes. When they are on multiple medications, sometimes OHAs might need to be converted into insulin. Keep watch on the antihypertensives, antiplatelets, and anticoagulants. They are prone to have decreased organ reserves, and sometimes specialty consultations like cardiology may be essential. Pain management is of utmost importance in these patients, as pain aggravates all the comorbidities. It can present as cognitive dysfunction. And here we do something called an on-arrival block, which helps us with the pain management. This is basically a small slide regarding the ASRA guidelines. These are guidelines that helps us to decide the neuraxial anesthesia in patients with anticoagulants and antiplatelets. So on-arrival blocks are regional anesthesia techniques that are given to the patient upon arrival to the emergency department. It decreases the stress response, it reduces the sympathetic response to pain. So the on-arrival blocks that can be given for a neck of femur fracture include a femoral nerve block, a PENG block, or a fascia iliaca compartment block. Newer blocks include iliopsoas plane block and articular branch of femoral nerve block. Now, once we have decided to take up this patient for surgery, it is essential to decide what we are going to do, what kind of anesthesia are we going to give. So what are our options? Either we can have a solely regional anesthesia or combine a regional with a general anesthesia. What are the advantages of regional anesthesia? in such patients. There is a reduction in the thromboembolic events, there is a reduction in the cognitive dysfunction, endocrine response to surgery is reduced, there is decreased blood loss, and postoperative respiratory complications seems to be lesser. But before giving a patient a spinal anesthesia, there are some things that we have to remember. There is a decreased LA requirement here because there is a decrease in the volume of the CSF and there is increase in its specific gravity. There are changes in the configuration of the intradural space. Pharmacokinetic and dynamic variabilities are present, and there is a decrease in the leakage of local anesthetic from the epidural space. The neuraxial blocks are technically more difficult to place in an elderly population because of osteoarthritic changes, inflexibility, and cartilage calcifications. In such cases, a paramedian approach to neuraxial blocks or an ultrasound-guided neuraxial blocks can be attempted. Most of these patients find it difficult to lie down in a lateral position for a longer period of time. So most of the times we are having to give a sedation. So when you give sedation in geriatric population, you have to be very careful because even a small dose can cause serious consequences like respiratory depression or hemodynamic instability or altered mental status. So it is better to avoid drugs like benzodiazepines, which can impair the cognitive functions in the postoperative period. You can go forward with drugs like short-acting opioids like fentanyl or drugs like dexmedetomidine infusion. In the intraoperative period, appropriately pre-medication has to be administered. Good 2 wide-bore IV cannula should be secured before attempting anesthesia. Routine pre-oxygenation, airway maintenance can be complicated, and the procedures, epidurals and spinals can also be more difficult. Intraoperative monitoring should include all routine ASA monitoring. Invasive monitoring like an arterial line might be required in elderly patients with when a cemented bipolar is planned. The cementing itself can cause variability in the hemodynamics, and it is easier to monitor the transient changes. Depth of anesthesia monitoring is indicated if general anesthesia is given. Maintenance of normothermia with forced air warmers and fluid warmers are important. Fluid management should be kept in mind. Both overhydration as well as dehydration can be dangerous. Usually a neck of femur fracture patient is posted for a bipolar hemiarthroplasty usually, and the positioning for that is lateral decubitus position. Some things that have to be kept in mind in a lateral position is that first you have to always confirm the site of surgery before positioning. Maintain the airway and cervical spine in a neutral position while turning. And after the putting in the lateral position, always plays an auxiliary role to prevent compression of the axillary vessels and brachial plexus. All the pressure points should be adequately padded, and they are frail, fragile patients, so the whole positioning should be done very carefully. So this is a lateral position that we do. After putting in the lateral position, all pressure points should be adequately checked, and you have to check for the genitalia and the dependent ear that it's not compressed. Another complication that happens in the intraoperative period that we have to keep in mind is a bone cement implantation syndrome. So it is a potentially life-threatening complication that occurs after the insertion of bone cement, that is polymethyl methacrylate, during procedures like a hip or knee arthroplasty. It is characterized by sudden cardiovascular and respiratory compromise. It occurs usually in cemented bipolar hemiarthroplasty. The incidence varies, and the mortality from bone cement implantation related cardiac arrest is up to 65 to 80%. The pathophysiology here, the most accepted form is the embolic model, where the cement pressurization increases the intramedullary pressure to more than 300 mmHg. So the embolization of fat, marrow, cement particles, fibrin and air happens, and it can get into the pulmonary circulation, which leads to an increase in the pulmonary vascular resistance, increase in the right ventricular afterload, causing an RV failure, and a decrease in the left ventricular preload, causing a systemic hypotension and hypoxia. Another possibility is a mediator release. The embolic material activates complement cascade, and there is release of histamine, serotonin, thromboxane, etc., which causes pulmonary vasoconstriction and bronchospasm. There are direct cement-related effects caused by the methyl methacrylate monomer, which causes vasodilation and myocardial depression. So how do you identify that this has happened? So there will be sudden hypoxia and hypotension. And this can even cause arrhythmias, including bradycardia, asystole, and pulseless electrical activity. There is pulmonary hypertension, and it results in cardiac arrest in severe cases. Prevention strategies include optimization of the volume status and screening for high-risk patients if the patient already has an RV dysfunction. Intraoperatively maintain normovolemia, pre-oxygenate prior to cementing. There should be a close surgical communication regarding when the cement is going in. Invasive monitoring for high-risk patients, including an outline or a CVP monitoring, can be useful. Consider vasopressor infusion during cementing in frail patients. It is always better to keep the BP on a slightly higher side when they put the cement in. Once you've recognized that there is a BCIS, how do you manage? The first immediate step is to give 100% oxygen, stop cementing if possible, give adequate circulatory support, increase IV fluids, vasopressors like noradrenaline or phenylephrine. Ionotropes can be used for RV dysfunction. Advanced support like CPR if arrest happens, and mechanical support like ECMO RVAD in selected cases. ICU monitoring might be required if significant event happens. Now coming to general postoperative considerations. First thing is DVT prophylaxis, taking into account risk factors like age, nature of surgery, immobility, and concurrent conditions such as heart failure. Good hydration should be given, early mobilization should be promoted, low molecular weight heparin or unfractionated heparin can be used, and thromboembolic stockings or compression devices can be used. Nutrition is important as it aids in healing and recovery. Blood sugar monitoring should be done continuously. Fluid management, major contributory factor for a postoperative morbidity and mortality. Acute renal failure is accounted for about 20% of the postoperative deaths in the elderly. Oxygen therapy as required. Pain plays one of the most important factor in the postoperative period. There should be pain assessment charts. Patient's posture and facial expressions can give you a clue. The pain assessment should be followed up at regular intervals. Substandard analgesia can result in problems. Inappropriate drugs, doses, routes, or assessment can happen. Monitoring should be done for sedation, respiratory depression, nausea, vomiting, ileus, pruritus, urinary retention, confusion. Rehabilitation, early mobilization, and physiotherapy are important. Another complication that can happen with an elderly patient in the postoperative period is the delirium. So it is a form of acute cognitive impairment that can increase postoperative morbidity. It presents with difficult pain management scenarios. It impairs postoperative rehabilitation, and it prolongs the hospital stay. So preoperatively, the risk factors include advancing age, preoperative cognitive impairment, white matter microstructural changes, medical illnesses, frailty, and benzodiazepine pre-medications. Intraoperatively, deep anesthetic levels, drugs like morphine or meperidine, other anticholinergics, increased duration of surgery, increased duration of anesthesia, fluid and electrolyte disturbances, and postoperatively inadequate pain control, need for mechanical ventilation or deep sedation, again benzodiazepines. So it is the postoperative cognitive dysfunction is a spectrum of diseases. It is a huge topic on its own. I'll just touch the basics. So in the immediate postoperative period, usually patient can present with agitation, disorientation. So that is the emergence delirium. In the first 24 to 72 hours, they can present as post-op delirium, which also presents with similar features like agitation or confusion and disorientation. If the symptoms last for weeks to months, they go into postoperative cognitive dysfunction, which is usually decreased with associated with memory loss or their cognitive higher mental function impairment. So what can we do? We have to identify the risk factors. There is no consensus or prediction tools exactly which predicts that, but assess for the risk factors. If you're giving the patient with a general anesthesia, do a depth of anesthesia monitoring. Targeting a BIS of 40 to 60 may reduce incidence of delirium. And avoid drugs like benzodiazepines. Give adequate pain management. Include regional anesthesia practices in your pain management strategies. So delirium prevention strategies include education targeted to the healthcare professionals about delirium and For the patient, promote daily physical activity, do a cognitive reorientation. Bedside presence of a family member can help. Give adequate sleep, early mobilization or physical rehabilitation, adaptation for visual and hearing impairment. Basically, get them back to their normal state, normal atmosphere as soon as possible. So, just to summarize, if you were presented with a patient, an 85-year-old male patient, who's presenting with a history of fall at home, maybe yesterday evening, sustaining a fractured neck or femur, and he is a known case of diabetes, hypertension, and IHT, and the last dose of antiplatelet was taken yesterday. The patient is posted for cemented bipolar hemiarthroplasty. All the routine investigations in ECG and echo are within normal limits. What would be your plan of anesthesia? So that is something to think about. Thank you.
I think Aparna asked one question. I think everybody will think. At the end of the session, again, we'll discuss and we'll come to some conclusion. I invite now Dr. Stephen to present his topic. Again, now Aparna finished a sick geriatric patient. Now Stephen is going to present a geriatric age group, relatively healthy patient. This geriatric age group, they need quality of life, healthy geriatric. Just to improve the quality of life, they are coming for these surgeries. So before going into surgery, we'll start with prehabilitation and we'll take we'll do the optimization prior to surgery. Then we'll do best intraoperative management. Of course, we are going to prevent and if at all any complications in the post-op, that also we'll try to manage best. Now, Stephen.
Yes, sir. I just confirm share slide move, sir.
It's okay. Okay.
Yes, sir. So good evening, sir. Good evening to everyone. First of all, thank you to everyone and thank you for the ISA Pthukkottai and Meenakshi sir for this opportunity. So in this session, we'll be discussing about anesthetic management in patients posted for total knee replacement. First of all, just refresh your mind about anatomy of knee joint and the innervation of knee joint. So the knee joint being one of the largest weight-bearing joint in the body, which is formed by the three bones, femur, tibia, and patella. And the cartilages around the joint will act as a lining of the joint and the shock absorbers. And the ligaments act as a cushion for the joint. And the synovial fluid lubricates the joint. So these are the components which maintains the integrity of the joint and favors a smoothing of range of movements. So coming to knee joint innervations, being anesthetist, the innervation of knee joint, any whatever we anesthesia going to give, we need to know the innervations well, because whenever we want to handle with analgesia, we need to know the innervations first. So the femoral nerve gives off nerves to vastus medialis, lateralis, intermedius, saphenous nerve, and superior medial genicular nerve branches to the knee joint, and the genicular branches from the posterior division is a branch from the operator nerve. The inferior medial genicular and middle genicular nerve is the branches from the tibial nerve, and the superior lateral genicular, inferior lateral genicular, and fibular nerve is the branches coming from the peroneal nerve for the knee joint. So this is a pictorial demonstration of nerve innervation of anterior and posterior capsule of knee, and the three plexus which is more important around the knee joints are subsartorial plexus, which lies along the medial side of the knee under sartorius, and which supplies skin over the medial knee and also the anterior capsule of knee joint. And the next plexus is the peripatellar plexus, which lies around the patella, and it innervates the skin over the patella and anterior capsule of knee joint. And popliteal plexus, which lies along the posterior aspect of knee joint, which innervates posterior capsule and intra-articular structures of knee joint. So these three plexus should be covered while planning for analgesia in the perioperative period for an effective analgesia. So coming to cause of arthritis, so most common causes being the osteoarthritis, which is almost most common in elderly patients, and then more common in females than males when it comes to elderly. And others causes are rheumatoid arthritis, which mostly present in younger age groups, and others are post-traumatic arthritis and post-ligament injuries may lead to arthritis after 10-15 years. Symptoms being stiffness and discomfort in movement in the knee joint, pain which is aggravated by activity, weakness, inflammation, and crepitus. So in this image, you can see the first image is going to be the healthy knee joint, and because of OA, there's a damage of the cartilage and formation of bone spur, leading to the narrowing of joint space. In the radiographically X-ray, you can see the reduction in the joint space as well as the cartilage damage, so which leads to stiffness and the decrease in the range of movements. So what could be the non-surgical treatments are non-pharmacological, maybe like the patient is not willing for surgery, you can ask them to use assistive devices and educate the patient to do physiotherapy like knee strengthening exercise, occupational therapy, and go for weight loss. And pharmacology therapy includes start with the oral NSAIDs, paracetamol. If the patient is going to the chronic pain component, we can even add weak opioids, and oral steroids and intra-articular steroid injection can be given if there is any inflammation in the joint. And intra-articular PRP injection is also widely used in some setups, and but results about intra-articular steroid injection and PRP is completely variable with the patient to patient. So coming to surgical treatment, in knee replacement, there are two types of knee replacement. One is total knee replacement and another one is partial knee replacement. Which partial knee replacement is not more commonly done in India. It is more common in Western countries. In partial, they do unicondylar knee replacement where only the affected condyles are most commonly medial condyle is involved. So they only replace the medial unicondylar knee replacements. In total knee replacement, they replace both the condyles. So the approach for the knee arthroplasty is there are various approach like medial approach, lateral parapatellar, medial parapatellar, and mid-vastus approach and sub-vastus approach. The most commonly used is the midline approach, is seen in the picture. So what is the goal of knee replacement surgery is to first of all is to give a pain relief for the patient and to improve the quality of life and be able to do the routine activities of the patient and to restore the normal limb mechanical axis of alignment. So this is the mechanical axis of alignment. This should be restored so that the functional range of movements can be restored, so that the patient can walk, go for a jogging or something so that the whole quality of life will improve. So why TKR? The TKR is now most commonly done orthopedic arthroplasty procedure in an elderly patient with multiple comorbidities. And in this TKR, the perioperative anesthetic as well as analgesic management is very crucial in a successful outcome as well as in rapid recovery. So coming to pre-op assessment, if you see demographic, the most of the patients, apart from if you come leaving the rheumatoid, in OA knee, the patient is going to be elderly, obese, with high prevalence of comorbidities, and they are going to have a polypharmacy. So in coming to polypharmacy, you should always review all medications. If the patient is on any anticoagulants and antiplatelets, and what will be the indication for anticoagulants. If the patient is on any anticoagulants, whether to stop or give a bridging therapy for the patients. If the patient is an antiplatelet, stop at least for 3 to 5 days before surgery, then proceed for surgery. So these are important things to note out in the preoperative period. And coming to comorbidities, the patient must be most commonly we see diabetes, hypertension, CAD, and heart failures in patients. And most underrated or most of the time we miss this feature is obstructive sleep apnea. The OSA is very important in these cases because patient with the OSA will be always like underdiagnosed in patients, with obese patient, and patient with the OSA has multiple factors in the post-operative recovery. And if the patient is on OSA, the patient may have a poor respiratory reserve. So after surgery, the patient will develop desaturation, hypoxia. So because of that, patient can't mobilize on the early basis. Patient can't be mobilized because of desaturation. Patient may need O2 support for day 1 or day 2. So patient will be mobilized on from day 2. So slowly patient may develop a DVT, which may lead to pulmonary embolism and everything. So in a patient with the OSA, the best is to prehabilitate the patient with the deep breathing exercise, and you ask them to use spirometry 1 month before surgery, then optimize the patient well, and then you can proceed for surgery so that post-operative period we can easily incorporate exercise everything in those patients. Apart from that, the other problem is the rheumatoid arthritis and OA knee. If the patient has a OA knee or rheumatoid in the knee joint, that means already it also has affected other joints as well as spine. So it may impact on neck mobility, which may lead to difficult airway. And if it involves the lumbar spine, it may lead to collapse of the lumbar spaces and may lead to lumbar deformities like lumbar scoliosis, which may have problem for us in doing procedures for a neuraxial blockade. So evaluation, routine blood investigation should be done. Apart from routine blood investigation, urine routine microscopy should be done always in these patients because they are more prone for UTI. And ECG, if any ECG is the ECG changes are there, without hesitation go for echo, because in this patient, what the clinical use routinely we use med score as a clinical assessment for cardiorespiratory reserve. But in this patient, we can't rely on the med score because the activity is completely limited because of some pathology like joint pain. They won't mobilize, and they can't, or they couldn't mobilize, so they won't prefer doing some of activities like walking and everything. So with that activity, we can't assess the cardiopulmonary reserve of the patient. So better, if you have any ECGs, you can go for echo. And always once you do chest X-ray, you can always ask your surgical team to do a lumbar spine X-ray, because as I said earlier, the patient has any arthritis and knee joint developed. Definitely there will be some arthritis at the spine level also, so that you can assess preoperatively whether any scoliosis is there, which level you can go for a neuraxial blockade. If so, which will avoid completely multiple pricks for neuraxial blockade. So as I said earlier, med score is not useful in this patient for cardiopulmonary to assessing the cardiopulmonary reserve. So optimization. So pre-op optimization is very important. In any case, any surgery, pre-op optimization is one of the key factor for to have a smooth intra as well as post-operative period. So first of all, the important is to manage a patient based upon their comorbidities. If the patient is hypothyroid, continue thyroxine tablet on the day of surgery and do TFTs and see the optimal levels. If the patient is diabetic, preferable keep the HbA1c level in the perioperative period less than 7 and maintain sugars accordingly. And if the patient is hypertensive, maintain BP in the perioperative period. And second thing is the prehabilitation. The prehabilitation is very important in these patients, because if the patient is educated well about a knee strengthening exercise, deep breathing exercise, and spirometries, it will be very easy for us to incorporate in the postoperative period. At the same time, nutritional supplement should be given, and educate the patient about anesthetic plan, surgical plan, and always discuss the patient about the risk associated with the surgery and postoperative everything. And if the patient is having any source of infection, start antibiotics for a period of 5 to 7 days, then proceed for surgery. And anytime patient is having any acute fever or any source of infection, don't just postpone the surgery. Don't go for a replacement surgeries. So the anesthetic implication in these patients are, as I said earlier, patient with elderly, obese, and OSA is a dreadful combination. Those patients will have very poor respiratory reserve, especially in supine position. When they go for supine position, they'll go in with a half anesthetized with a neuraxial blockade. The patient may land up in difficulty in breathing, leading to desaturation, hypoxia, and everything. And one more important history you should always look in the preoperative period is if the patient is having any irrelevant talk in the home, or any forgetfulness, like patient is not able to remember what he had in the breakfast or any meal he forgot, then these patients have more risk for emergent delirium in the immediate post-op, and the development of post-operative cognitive dysfunction in the late period. And as I said earlier, the patient having ONE will definitely have some arthritis in the spine, and lumbar scoliosis and obesity. These three will be a difficulty in positioning, as well as procedural difficulty for neuraxial blockade. And because of the restriction in the neck mobility, patient may have difficult airway also. So these are some of the X-rays. Patients coming for X-ray or lumbar spine X-ray for the patient coming for TKRs. You can see so much arthritis in the knee at the spine L4, L5 level, L5, S1 level, and some sort of scoliosis also. And you can see the osteophytes which are started developing between the vertebral body and causing the fusion of the joints. And the same other X-ray, you can see obvious scoliosis in the L2 to L4 level. And you can see the osteophytes starting developing in the L4, L5 vertebrae, which is started to fuse. So this means the neuraxial procedures in TKR surgeries is not as easy as other surgeries, because this patient also has some issues in the spine. So always do a spine X-ray, and then you can assess yourself, and you can select some space which is better space from this X-rays, and then proceed for surgery or proceed for procedure, so that you will avoid multiple pricks. So if you are not able, if you are accessible to the USG, you can also USG as a tool for assessing the spine. It can be useful in patient with obese patient with a deformity spine deformities, or any angstpon is there, fused spine is there. So either you can use this pre-procedural scan or do a scout scanning before performing a neuroaxial blockade, or even you can use a real-time USG guided central neuroaxial blockade. So the two approaches, most commonly used approaches for USG scanning for spine are, one is transverse view, in which the curvilinear probe is placed in a transverse orientation to look for the interspinous window, and you can see until you see the thecal sac. This is a thecal sac, and you can see the posterior complex and anterior complex. So you can measure the distance from the skin to the posterior complex. So accordingly, you can proceed with the spinal epidural. So other view is the paramedian sagittal oblique view. In this, we keep the probe in a sagittal plane in the paramedian area and look for the interlaminar windows to look for thecal sac. This is a thecal sac. This is a posterior complex and anterior complex. Again, we can measure this distance and manipulate the epidural spinal needle accordingly. So one more most famously asked question from the surgeon point of view to anesthetist is like whether to proceed for a single stage bilateral TKR or not. So we can say that when to avoid in patients are avoid a single stage bilateral TKR in patients with extreme age groups like age more than 70 years, and but decide only based upon the preoperative status of the patient. Some patient of 60 years will be more of more comorbidities be there, so avoid those patients if you doing a single stage bilateral TKR. Others as patients suffering from severe cardiopulmonary disease like severe COPD, heart failure, CAD with poor LV function, severe pulmonary hypertension, it's absolutely contraindicated for single stage bilateral TKR. And patient with obesity with BMI of more than 40 is absolutely contraindicated. And patient with uncontrolled diabetes is also contraindicated because of the risk of infection in both the joints. So what is the choice of anesthesia? So the two types of anesthesia which usually give is, one is combined spinal epidural anesthesia or spinal anesthesia versus general anesthesia with nerve block. So the pros and cons are, the pros are for neuroaxial blockades are reduces blood loss, less PYNV, and less usage of opioids, which leads to improved post-operative pain control. The patient can be easily mobilized faster, and with epidural, there's a lower rate of DVT and pulmonary embolism. The cons include patient can develop hypotension, bradycardia, PDPH, and urinary retention. Urinary retention is one of the important problems followed by the combined spinal epidural anesthesia. Whereas in general anesthesia, the pros are patient won't have any awareness, patient will have a controlled airway, and the cons being the higher risk of PYNV, potential for delayed recovery, and emergence delirium in the immediate post-operative period, and patient may develop POCD in the late periods, and there's increased risk of pulmonary complication those patients because we're dealing with the elderly, obese patients in most time of TKS. So our preference will be going for a central neuroaxial blockade because patient being geriatric with multiple comorbidities and with neuroaxial blockade, there's a superior post-operative pain relief, and patient can be rehabilitated and mobilized so fast in the immediate post-op, and requirement of sedation is far less compared to hip surgeries or shoulder surgeries because the position is being the supine compared to hip where is a lateral position. So intraoperative standard ASA monitors are used, patient disposition in supine position, and careful paddings are done, and use for forced air warmers to prevent hypothermia and shivering. As you know, in arthroplasty OT, the AC will be like a 16 degree, 14 degrees in temperatures, and you can also use fluid warmers if necessary. So expected complication intraop is, so being a patient with obese and elderly, cautionally use sedatives. Sometimes mild dose of sedatives can lead to deep sedation, leading to hypoxia and desaturation. And bone cement implantation syndrome is rare in TKRs because only 20 to 30 grams of cement are most commonly used in TKRs compared to hip replacement or bipolar. Almost 50 to 60 grams of cements are used. But you may seem to have a transient bradycardia, hypertension, desaturation during or after cementing. This may be because of entry of microemboli into the systemic circulations. And always be vigilant during tourniquet release because it's done at most at the end of the surgeries. So always be there when the patient is tourniquet is released in patient. Patient may also land up in bradycardia, hypertension, and even cardiac arrest at the time of tourniquet release. So common complications in the postoperative period include as we said, nausea, vomiting, pruritus if the patient is given uraxyl opioids, and urinary retention is the most common problem encountered in the postoperative period, especially in the elderly patient with the prostatomegaly in male patients. And other problem is a DVT, pulmonary embolism, in which prophylaxis is very critical, and delirium, cognitive dysfunction in elderly patients. So the ERAS integrated protocols for all TCAR patients followed in our hospitals are to start oral liquids at 1 hour after surgery and solids at 4 hours, and to always follow multimodal anesthesia and trauma prophylaxis, and do early ambulation, physiotherapy, and rehabilitation as fast as possible after surgery. So the components of multimodal anesthesia, what we follow in our institute is we always combine regional nerve blocks in the multimodal anesthesia. So regional nerve blocks will counter the acute pain caused due to surgical process, and we'll also add injection paracetamol 1 gram QAD and injection ketorolac 30 mg BD, which will encounter the musculoskeletal pain resulting from tissue injury or tourniquet. And we'll also start pregabalin 75 mg ONHS for all because it will encounter the neuropathic pain caused by the presence of free nerve endings and nerve injuries. And if the patient is a part of a chronic pain because of OA knee or infection, even buprenorphine patch or fentanyl patch can be used in the postoperative period. So always remember the regional nerve blocks should be a component of multiple anesthesia for a effective analgesia in the postoperative period. So coming to regional nerve blocks, first of all, the gold standard is going to be the epidural infusion, which is the gold standard for any postoperative analgesia. But problem with epidural anesthesia is urinary retention, pruritus in the postoperative period. If the patient is catheterized, the patient can't mobilize with a Euro bag. So patient will feel reluctant in mobilizing with a Euro bag. So the epidural infusion is slowly declined, and then we started giving femoral nerve block in patients with patient in the postoperative pain relief. Problem with femoral nerve block is patient will have a muscular weakness, especially quadriceps muscle weakness, so that when the patient is mobilized on the POD 1 post-op day 1 or same day, the patient may buckle and fail. So to avoid that, and the ERAS integrated protocol has been included in almost all hospitals where TCAR patients are mobilized on the same day or on the POD 1. We started practicing motor sparing pure sensory nerve blocks, in which anaetacanal blocks are family used. So like blocks like subsartorial blocks, which is called dual subsartorial block, which is widely used in our institute, and modified anaetacanal block, and modified 4-in-1 blocks also used in the infiltration techniques like IPAC and LIA is widely used in the Western countries. So anaetacanal blocks. Anaetacanal you all know is a musculoapneurotic tunnel extending from the femoral triangle apex to the aorta hiatus, and there is a vasoactin membrane seen in the aorta canal, and the vasoactin membrane is absent in femoral triangle. Why vasoactin membrane is important? Because the vasoactin membrane is the one which separates the saphenous nerve from the nerve to vastus medialis. Because nerve to vastus medialis is also important nerve which gives innervation at the medial side of the knee joint. And the proximal aortic canal starts from the entry of saphenous nerve with femoral vessels, and middle aortic canal exit of saphenous nerve with descending genicular artery, and distal aortic canal starts with the entry of femoral vessels into the hiatus. So the dual subsartorial block, which is called DSB, which is widely used in our institute, which is a combination of 2 injections. 1 injection at the distal femoral triangle and second injection at the proximal or mid aortic canal. So the first injection which is given at the distal femoral triangle is which blocks the anterior innervation of the knee joint. Second injection which will block the posterior as well as intra-articular innervations. So as I said earlier, it is recommended to block the nerve to vastus medialis in the femoral triangle rather than aortic canal, because there is a separate facial sheath called vasoactin membrane which separates the NVM from the saphenous nerves. So the sensory innervation of incision site being the proximal half supplied by the NVM or distal half by the saphenous nerves. So coming to the this is the zona anatomy of distal femoral triangle, in which we see sartorius, femoral artery, femoral vein. This is saphenous nerve. This is the NVM. So the injection is made almost 9 o'clock to 10 o'clock position to the femoral artery, so that it directly can block saphenous nerve as well as nerve to vastus medialis. So once the distal femoral triangle injection is done, then we are moving the probe caudally. Look for sign of 3. This is a sign of 3, which is the end of the femoral triangle and the start of the aortic canal. So once we see this, we move the probe more caudally, almost 2 centimeters from this point, and injection is given at 12 o'clock position to the artery in the proximal aortic canal, or even we can give at the mid aortic canal. So the first injection directly will block saphenous nerve and NVM, which is given at the distal femoral triangle, and it also blocks the substernal plexus and peripatellar plexus. And second injection, it will going to block saphenous nerve directly, and distally, when the injection is given, it passes through the drug spread along the recta hiatus and block the popliteal plexus. So as we said earlier, the 3 plexus are covered, and most in pain generating nerves like saphenous and NVM is also covered. But it does not cover the skin over the anterolateral and posterior aspect of knee, which is covered by the lateral peripatellar plexus and the PFCM. So next most important thing after multimodality is trauma prophylaxis, because the incidence of DVT and pulmonary embolism in post-TKR patient is not uncommon, is very common. So the key management is a prophylaxis. The prophylaxis is given, prophylaxis is done properly in patient, it can be easily prevented in patients with obese patients coming for TKRs. So the risk factors include advanced age, obesity with a BMI more than 35, and patient has any history of DVT, pulmonary embolism, the previous surgeries and anything, and patient has a history of any cancer, and patient has any prolonged immobilization from the last 3 months, and if the patient is undergoing any revision arthroplasty surgeries, are more prone for DVT and pulmonary embolism. So we usually follow mechanical pneumatic compression devices, and Ecosprin 150 mg OD is given in all patients till the patient is actively mobilized. And in those patients with risk factors above, like advanced age, obesity, patient is obese, has a history of any DVT and pulmonary embolism, and patient is going for revision surgeries, we add either low molecular heparin or unfractionated heparin in those patients until the patient is mobilized. So next is the early mobilization, which is very important in TKR surgeries, because patient should be mobilized fast and rehabilitated fast, so that the patient recovery will be fast. So what we are trying to achieve from TKR patients is like, first of all is to alleviate the pain and facilitate them to do early mobilization and physiotherapy and decrease, so that we can decrease the complications. So once the complication and everything is reduced, the length of stay and the cost effective, everything will be effective. In the long term, patient, when the TKR is successful, the recovery is fast, the patient will tend to mobilize more, and the patient have a functional range of movements will be good, and they improve long-term functional outcomes and decrease incidence of chronic pain and improve patient satisfaction also. So in summary, the thorough preoperative assessment and optimization is a paramount, and regional nerve blocks should be a component of multimodal analgesia. The multimodal analgesia is a cornerstone of effective pain management, which minimizes opioid use and facilitates rapid recovery and successful outcomes. And optimal perioperative management, which integrated ERAS protocol, is essential for rapid recovery and early discharge. Thank you.
Thank you, Stephen. I think Dr. Stephen has covered all the important points. I think we can move on to questions, whatever we have received. First question.
Stop sharing the screen.
Stephen.
Yes, sir.
First question is the important question what we have received from Dr. Muthukumar Rajagopalan. That is, when patient with long bone fracture with fat embolism symptoms, what anesthesia is preferred when CNS is not involved? I think is asking the type of anesthesia we prefer. Usually, pulmonary embolism, they have a significant hypoxia. In a severe case, usually severe case, we don't take them for surgery. Once they are relatively optimal, like their tachypnea settles, their oxygen requirement is very minimal, or they are not on oxygen, and there is no inflammatory marker, rise in inflammatory markers, like there is no fall in WBC count, like severe white count fall might be there in severe inflammatory response. So those cases, we always go for regional only, neuroaxial technique only, either spinal or some combined spinal epidural only. And obviously, as is mentioned, is any cerebral fat embolism features are there, we try to avoid the surgery. In case if the patient is very sick, we put we give general anesthesia, and then we proceed with the external fixator first instead of going with nailing. So then they are in critical care. Once they are relatively recovered, then we proceed with nailing. Then I hope the answer, I have answered the question. Next question is by another doctor. That is a very interesting question. Like, have you ever heard? Okay, sir is only written. I think. Have you ever heard cement reaction and in your hospital? If yes, how you managed it? Sir, our center is a high volume center. So though it's a rare complication, we have seen some patients. So when we are fully prepared, I think it is easy to manage. When we are not fully prepared means something like if you don't have arterial line, and if you are not closely watching the hemodynamics, especially heart rate, and then we will be getting into more trouble. So the idea.
Actually, that question was from me.
Yes, sir.
Because see, so I have been in anesthesiology for 35 years,
Yes.
doing R2 also, but I have never heard and nobody has informed me about the reaction. Sometimes they say some hypotension occurred. Same that is applicable for fat embolism also. That is the reason I am asking you, as you are doing it completely, you are dedicated for orthopedics. For us, it is one among the surgery. That's all.
Yes.
So once you are dedicated, that is the reason I have asked, have you ever heard? You might not have noticed, but your seniors, because in their Ganga Hospital for 25 years, whether they have seen or heard, how you have managed. Management, we know. I am asking the direct experience. Yes or no only, because I have not seen. Any case, just sometimes they say hypotension is there. They will say, that monitor will say, but we don't take it as a cement reaction. Right hypotension fluid. So far, I have not seen. Fat embolism, I have never seen. I have never seen. So whether it is projected so much, it is there, long bone fractures, we say. Because you are doing, I asked just a yes or no, just to sensitize the people, whether you have seen on your own.
Sir, fat embolism, we see plenty, sir. And our trauma numbers are very huge. So plenty we have seen. Probably every week I see, if I say, at least
But
one.
cement reaction very rare.
Reaction probably every 6 months, 1 year I see one. But majority of them are manageable with fluids and minimal inotropic support. But only thing, the problem comes how early we notice. Suppose if already patient is having some low ejection fraction, or already patient is having severe COPD, those patients are getting into next level problem. They go into hypoxia.
But all your fat embolism patients, how will you manage?
Initially, the two kind of presentations are, one is kind of happy hypoxia people. Patient presents, young people, they come with 91 or 89 saturation, and even up to 85, they don't complain, majority of them. And they have even 120 heart rate, they don't complain palpitation also, just because our pulse oximeter and ECG, that picks up the tachycardia, and our pulse oximeter only picks up the saturation.
When you confirm in your institute, when you confirm that it is a case of fat embolism, because this tachycardia, tachypnea will be there everywhere. So when you confirm that there is a case of fat embolism.
If it is a kind of applying this criteria, more than criteria, I think if long bone fracture patient, if the patient is not having significant respiratory issues, probably he is not suffered from recent pneumonia, or he was all the time okay just before fracture, and there is no chest injury. Usually rib fractures are there, lung contusion and pneumothorax, hemothorax, those things can also cause hypoxia.
Then
if those things are not,
then if you suspect, how will you manage the fat embolism? Immediately you will
yes,
go for management, is it?
Yes, sir. If there are two kinds of fractures, sir. One is closed fracture, that is non-compound. Another is compound fracture, open fractures. Open fractures, if very contaminated wound, everything is there, better to apply external fixator, sir, especially. Because we cannot wait, at least if the hemodynamic stability is there, at least we can give regional anesthesia.
If you suspect fat embolism, how will you manage? I'm asking.
Yes,
Whether
sir. We
you
have to give oxygen. Number one, you have to give oxygen support. If hypovolemia is there, you have to correct hypovolemia. And if patient is having closed fracture, non-compound fracture, better to wait. Better not to operate in the initial phases. You have to wait.
No, I'm asking the perioperative period.
Intraoperative period, sir.
Intraoperative period.
Intraoperative period, as like any other, you have to give oxygen support. Majority of them, mild fat embolism, we can support with oxygen and manage, sir. And the thing is, some of the long bone fractures, if probably if repeated reaming they are doing, very few people intra problem, the problem comes in the pre-op. Majority of the time we can decide in the pre-op and we can avoid. Intra, if at all, majority of the time it is manageable, so with oxygen. It is not a problem in intra. And I hope you answered your question, sir. Yes. And the third question asked by Dr. Anusha Nayak. Surgeons ask us if we can do some cementing for a particular patient. Yes. Suppose patient is having severe compromised COPD, already patient is having significant V's or decreased SpO2 on oxygen support or significant breathing difficulties there. Compromised, basically to say compromised pulmonary system. Or patient is having low ejection fraction, and or the third group is frail. They don't have any comorbidity, they are frail. The weight is very less, their mobility is very less. Those patients, if possible, better to use a non-cemented technique. Nowadays, a lot of techniques are there. Without cementing also, we can only think is it's costlier, sir. It is costlier, and but at the cost type with the cost, I think we can avoid cement. Or there are some techniques they can use minimal cement also. If at all we use cement, we have to be very vigilant in a sick patient, especially.
They're using some tablet like thing. They're getting 1,000 tablet, 500 tablets, then make it as a gel. So many things orthopedic people are doing now. Ortho and dental, we can't even imagine they're doing something.
Okay, sir. So non-cemented, a lot of instruments have come, sir. In our hospital also we are using. So only thing is it is costlier. So that is why depends on the patient population, sir. And another question. I think Dr. Narmada Youngstay, she asked, does the choice of anesthesia, GA versus regional, affect the incidence of post-op delirium or something? I think she meant to ask, I think, post-operative cognitive dysfunction mostly, I feel. I think our choice of anesthesia in all geriatric patients is obviously regional, but very rarely we give general anesthesia only in indications where sometimes they are associated with head injury or patients with or any problem. We are not able to do the neuroaxial technique because of the spine surgery, and already patient underwent in all this thoracic lumbar spaces. There is no, even then those cases, I think we can give only if you are able to manage with the spinal anesthesia alone, that is okay. But the question is whether GA or regional, whether it is going to affect the incidence of post-op delirium. I feel incidence is less with regional, sir. Even literature also says like that. But the complexity that in general anesthesia, obviously we use more drugs. Without regional anesthesia, I think pain is the main problem. The important aspect of this post-op delirium is mainly, I feel, pain is an important component, sir. So without regional, it is very difficult to manage the pain. I think obviously they are more prone for delirium. And the next question is asked by Dr. Priyanka. She asked, do you place adductor canal catheters for TKR surgeries? How do you manage to give pain relief for 2 to 3 days if not putting catheters? Yes, it's a very good question. And previously we used to, in the few years ago, we used to put catheters. Nowadays, with multimodal and majority of the cases, we give this dual subsarterial block. With very rarely surgeon gives local infiltration, that LIA analgesia also, with dexamethasone. With this dexamethasone and this adductor canal block, majority of the patients get good pain relief on first POD. Challenge might come in some patients in second POD. Obviously, they are supported with multimodal. Invariably, everyone gets paracetamol. invariably, if there is no contraindication, they get NSAIDs, and majority of the patients get injection tramadol also, unless somebody is nauseating or something like that. And with, if necessary, small group of patients, they might require repeat block on the first POD, again with dexamethasone. So first 2 days only the pain is the problem. From third day onwards, whatever I told, that multimodal with multimodal tramadol, paracetamol, if not contraindicated NSAID, I think we can manage. Small group of people, some people need this neuropathic pain induced issues, that is managed with that pregabalin. Some people of some group of people need that pregabalin. Only catch is that some old geriatric age group already on multiple drugs. If you put pregabalin, you have to be careful whether they are sleeping or overdosed in the next day. So in that case, you have to avoid that medication. I think we have covered all the questions, sir, and if you have time, I think a few points I want to emphasize, sir.
One thing, moderator, sir. One
Yes.
question from Dr. Venkamabba Tummala.
Yes, sir.
Question itself is not clear. It is she's asking unrelated to previous fracture femur. So that conveys no meaning. Unfortunately, we could not interact directly with her. So that question can be omitted.
Okay.
Moderator can go for wind-up points.
Yes, sir. So Stephen told one of the important, all the patients coming for that knee replacement, majority of them are obese. One of the important aspect we miss is.
So sorry, sir. One Dr. Naresh Paliwal.
Yes,
He is from Maharashtra.
yes,
He is such a senior person, and I think he is one of the pioneer in India regarding segmental spinal. So sir has asked some question. Which drug you prefer?
Yes, sir. We prefer low volume hyperbaric only, sir. But some of the institutes are happy with this isobaric drugs also. Majority of the institutes are happy with isobaric. But we have used very limited cases. We are using low volume spinal, that is hyperbaric only we use, sir. With that, we are not having much.
He is a strong vociferous supporter for segmental spinal. So even now I was discussing with him regularly. Even then I am using only this hyperbaric because whatever we know, only we can do that. But he is doing all the procedures under segmental spinal only. He can exactly block. We have to appreciate him. He can block only 4 nerves, 5 nerves. He has his own formulas. He has his own formulas. He is doing only freelancing now, but he is such a strong supporter of segmental spinal. So if a book is written, definitely he has to do that. In India, it is segmental spinal means he is known as a segmental spinal man. It is something surprising. So we will appreciate him, but we will do the same thing till we are convinced. Because he has every formula he will say. If you want T1 to T4, he will say the interspace, he will say hyperbaric. Then if hypobaric is not available, how to prepare? I have asked him several times, but I have done only 2 cases with him as a telemedicine teacher. He is a good teacher. So we will share his number with you because you people are doing only orthopedic procedures. He is a very simple man, down to earth man, but he is such a great scholar in segmental spinal. I think only he is doing segmental spinal, not intubation. Yes, sir. Please take over.
Yes. So regarding this isobaric drug, sir, one of the challenges is lateral position. So we are giving spinal in supine, hyperbaric drug. Again, immediately we are turning the patient to lateral. So in this particular situation, I think sometimes level might go up. The patient might be having, if COPD is there, he might end up in, if high spinal, he might have a patient might develop breathing difficulty or might end up in bradycardia or hypotension. So lateral position, definitely, I think it has roles, sir. And obviously, the many literature and many institutes, they say if patient has some cardiovascular issues, obviously it is isobaric drug is useful. Then regarding that knee replacement and this, what we commonly encounter in obese patient is commonly we miss also, that is obstructive sleep apnea. So if whenever possible, we have to find out early that whenever we do pre-op evaluation, we have to identify the patient with OSA. As we know, we routinely ask questions where daytime sleepiness or so and so, and we find out. Once we found, I think optimization begins with if the patients are not convinced, better to do the sleep study, and we have to start the CPAP early. If CPAP, if they come, the results are even more better. Especially morbid obese patient with OSA, if they come for surgery, preoperatively, if they are optimized with CPAP, I think the post-op pulmonary complications are very less. And recently, I think Miller, even textbook of Miller also added one topic like perioperative brain health initiative. I think all the geriatric age group, we have to be very careful in BP monitoring, preferably, especially when we suspect major blood loss, revision surgeries, better to have intra-arterial line. I think keeping the BP on the higher side, it is useful to maintain all the vital organ perfusion. In fact, post-op delirium, or for all the aspects, it is very useful. And in that brain health initiative, it is mentioned even maintaining, preventing hypothermia also very crucial. So as far as possible, we have to use the warm fluids and fluid warmers, and even we have to use the air warmer also to prevent hypothermia. So regarding this cement problem, sir, again I will come to that. So one is prevention, and that is choosing the patient, right patient. If compromised patient will not do cementing. Second one is better to have an intra-arterial line. Earliest time you have to intervene. The point is, especially a lot of postgraduates and young people are here. We have to be very vigilant. If the BP, systolic BP falls from 110 to even 90, we should not be just take it as just 20 millimeter fall is there. The 20 millimeter may be next fall might be even more drastic. So better to address it early, quickly. Then the problems of severe hemodynamic compromise and major problems are avoided. Any other important aspects, sir? You have?
No, sir. You are the boss in that. If there is nothing more to add, we can go for winding up.
Yes, sir.
Okay.
Yes,
See, I thank this entire faculty from Ganga Hospital. In this juncture, I want to recollect the last webinar, that is our 35th webinar, titled as Tubeless Anesthesia. There, the faculty were from JSS Medical College, that is Dr. Aparna's Medical College. She is not the owner, it is alumni of JSS. Because Dr. Hirleka was the PG who participated in that. She was talking about physiology of pre and para oxygenation. It was followed by Dr. Meghana. She was talking about HFNO. It was followed by Dr. Anup. He was talking about, but he has clearly described the tubeless anesthesia techniques with videographs. And it was moderated by Professor JSS Medical College, Dr. Anil Kumar, and 856 delegates attended it live. So now this orthopedic webinar, that too with Dr.Reena, postgraduate, she has clearly explained about that fat embolism. It was very clearly followed by Dr. Aparna for this fracture neck of femur. And our Dr. Stephen from Puthukkottai, actually, we want to mention that he has discussed about a knee replacement. But I want to appeal all these youngsters, they have to present not like catching a flight. So they have to go for that informal mode. That is the idea we are projecting the youngsters because it should be the first step for them. Everybody was in a hurry, probably the hidden anxiety neurosis of these speakers, but it was excellently managed by Dr. Guru, our moderator, because the way in which he speaks, that speaks volumes about his expertise and experience. That is what we want to have for the youngsters, because mostly postgraduates and youngsters are listening to this. They want to have the take-home points, and the take-home points is given by the moderator in a very, very concise format. what exactly has to be done, he has managed. So he has offloaded the volume of questions thrown on the faculty. These three people, he has taken it over. So he is really a true leader. A true leader should defend their faculty, and he has allowed you to speak. He was keeping quiet, but he has answered all the questions. So I thank Dr. Guru for his wonderful moderation, and I thank all the delegates who are attending this webinar. Now it is over to Clarinet to conclude for the concluding remarks and winding up the session.
Thank you so much, everyone, for joining this session. Clinic is really glad to have all the brilliant people together. So with all your permission, I'm closing the session for today. Thank you so much, everyone.
Thank you.
Thank you, sir. Thank you, sir.